Yeah, I guess I can get
Uh,
started.
yeah, that sounds great.
All right, cool. Hello, everyone. My name is Jada Nixon. I'm head of clinical ops at Zivian Health, and welcome and thank you for joining us today. We're very excited to hold this special webinar, Dermatology for the Non-Dermatologist, which is hosted by Dr. Knox Beasley and co-sponsored by our friends and partners at Modern Ritual. For those of you who are not familiar with Zivian, Zivian Health is a compliance and quality platform that supports independent providers and the companies that work with them. And we empower advanced practice clinicians to form meaningful and healthcare collaborations with physicians. And we help healthcare enterprises scale quickly, compliantly, and sustainably. As a quick note, there will be a Q&A session today, as Eliana already mentioned. So please, if you have any questions, drop them in the chat and we'll pass them along to Dr. Beasley during the Q&A portion of the webinar. And now I'd like to introduce Eliana Goldstein. Eliana is the co-founder and CEO of Modern Ritual, which she founded alongside her mother, dermatologist Dr. Beth Goldstein. Modern Ritual's virtual dermatology platform helps patients and primary care providers quickly access board-certified dermatologists on demand. Eliana, I'll let you take it from here to share more about Modern Ritual and get us started.
All right, thanks, Jaden. I will go ahead and replace the spotlight so that way y'all can see my face. I'm Eliana. I am excited to be here with you all today for the next 40 or so minutes. I'm going to try to take as least time as possible because Dr. Beasley is the one with all of the content and education, but I'm going to go ahead and share my screen. Let me know when you all can see that. Is it up? Thumbs up? All right. I'm seeing some nods with Dr. B. So yes, as I listed here really quickly, I'm the founder of Modern Ritual alongside my mother, who is Dr. Beth Goldstein, a dermatologist. And then funny enough, my father, who I'll talk about in a little bit, is a primary care physician. And so we definitely have seen kind of the full spectrum when you see who's going to someone to talk about their skin. It's usually one of my friends, growing up for many, many years. But for those who are attending today who are not already working with us, feel free to scan this QR code to learn a little bit more. And again, grateful for Zivian for co-hosting this with us. I'm going to dive right in and just introduce a little bit about Modern Ritual and then hand it over to Dr. Beasley, who will talk through a few case studies and some of the many questions that he sees from non-dermatologists who have sent questions to him both by using Modern Ritual and then also over the years, and some helpful tips and tricks. And then, of course, at the end and throughout, like I mentioned, Q&A in the chat. You can see here Dr. Beth Goldstein, my mother, like I mentioned, she's been a dermatologist for the last 30 years. We started our company really to help expand access to rapid dermatology care. And so if you have ever been dealt with any of these problems here on the left, when you're dealing with patients who have dermatology concerns, that's really why folks come to us at Modern Ritual, is to increase collaboration between dermatologists and non-dermatologists and increase access for patients who are waiting weeks to months to be seen in person. So without further ado, I told you I'd be very quick. I'd love to introduce Dr. Knox Beasley, who received his education medical school at Tulane and then proceeded to work in virtual dermatology in the Army. He is such a wonderful I feel so lucky to get to work with Dr. Beasley. Truly, he is just a joy, and all of the folks who work with him say the same. I will also highlight that he is now in North Carolina, which is where I'm calling in from today. Loves to be in outdoors, and so I like to always say, we are all clinicians, and also we have lives outside of medicine as well. So it's two young kids, and so I will hand it over to Dr. Beasley from here, and I will go ahead and spotlight you as well.
Perfect. All right. Hi, everyone. My name is Knox Beasley. I'm a dermatologist. I've been doing virtual dermatology. I started actually in the Army close to 10 years, 10, 11 years ago. We would do telederm for soldiers literally all over the world, where we would get their complaints in and then try and triage them and help out as much. Sometimes it was challenging based on what part of the world they were in and how much access to medical care they had. So it's a little bit easier when we do it in the United States, since we have everything at our fingertips. What I'd like to go through is sort of some common questions that we encounter from primary care, some common themes. Also give you an idea of like how we would answer a consult at Modern Ritual, so you have an idea of how things work as well. So typical things we get, obviously moles and spots. I think this is where like we really can help with Modern Ritual, because you have a patient who's got a spot, it's not clear, you know, is it benign? Does it need a biopsy? What's going on? You know, the dermatologist, a 4 or 5 month wait, and you're just like, I guess, do you wait for the spot or what do you do? So this is a time where you can get a photo, we can get to us, get to me or one of the other dermatologists, and we can be like, hey, look, this thing looks totally benign. I would just have the patient monitor it. Or like, you know, this does look a little bit more atypical. Like I do think this needs to be seen in person, or just it needs to be a shave biopsy. And some people, it's like, hey, if you could do the shave biopsy, fantastic, you know, or a punch biopsy. I try and let you know what I would do. Treating hair loss. A lot of times in dermatology, hair loss is like an, oh, by the way, like as I'm leaving the room, I get someone to say, oh, by the way, all my hair is falling out. So that's usually like when that happens. So if that happens to you as well, just be like, hey, I've got just the thing for you. I do enjoy treating hair loss. We do acne, wound care. Obviously, rashes are a big chunk of what we do as well. And we have a pediatric dermatologist as well too. So she's fellowship trained as well. So this is like a standard photo that we would get of, hey, I have this patient with this rash. You know, what do you guys recommend? What do you think? I don't know if anyone wants to take a swing at what this is and
Feel
have a
free to use
chance
the
to
chat
shine.
here if there's any guesses for what this might be. We'll give it a couple seconds for people to see.
Anyways, drum roll. This is psoriasis. Nailed it right at the last second. So this would be like a case highlight of something we get. So a consult came in. This is a real case. I don't have the photos from it, but it was a 45-year-old female with flaky, itchy, irritated scalp. Looked like a scalp psoriasis. Typically, when I'll give you a response, I'll say, hey, this is what I use. This is how long I like to use it for. If it comes to different strengths, I'll say, hey, I like this strength and this vehicle. And then I'll try and give an alternative if I can. If I think, hey, for it's less severe, you could try this. And you can also send me in a question afterwards if you're like, hey, you know, in talking to the patient, actually, they told me this now. Does that change anything? So I'm always happy to have a back and forth as well. It's not a one-time event. Again, and this all gets answered within 24 hours, usually same day. Like if you put it in that morning, we're going to answer it that day, more than likely. So as far as psoriasis, this is actually about 1 to 3% of the population. It's chronic. There's no cure, unfortunately. The more we research about psoriasis, the more we find out it's linked to all these other conditions like hypertension, different arrhythmias, dyslipidemia. So it's definitely something that we want to get under control, because this hyperinflammatory state, we really want to dial that back. This is a quick tip I learned from a rheumatologist to check for psoriatic arthritis, because sometimes you're like, is it osteo? Is it psoriatic? Like, what's going on? But an Achilles enthesitis, which is really where you just sort of mash on their Achilles, right where it inserts, and if that's painful, that's an indicator that it could be psoriatic arthritis. Also, usually it's a morning stiffness that gets better with use, as opposed to osteo, which would be more, hey, at the end of the day, my joints are hurting. Next slide. These are some really good classic pictures of psoriasis. We get these well-demarcated silver scaly plaques, as opposed to eczema, which we'll talk about, which is on the flexor surfaces. You're going to see psoriasis more on your extensor, so on the outside of the elbows, the knees, lower back is a common place, the scalp. Those are all really common areas for psoriasis. So I don't always biopsy psoriasis. If it looks really classic, then I don't biopsy it. It's a clinical diagnosis. If I'm a little bit like, it looks psoriasiform, but I want to make sure it's not anything else, then I will do a shaved biopsy. Would be better. You're going to see psoriasis higher up in the skin. So a punch biopsy getting down to fat, we don't really need to get that deep. A shave is great. Smile, you can treat with topicals, clobetasol, which is a super potent steroid, hydrocortisone or a destinide, lower potency face, sensitive areas. When it gets to be all over to the point where like the tube of cream that you give them is gone in like 3 days, or it's just all over and on their back in places they can't apply it, then really you need a systemic treatment, which is what we call biologic therapy. These things like Humira, Otezla, different things like that. Phototherapy is where we use like a special wavelength of light. It's great. It has very few side effects, probably the fewest side effects of anything you can do. It's done in office a couple times a week. That's the hardest part, is logistically, can they come? And then, reason 482 to stop smoking is your psoriasis would get better as well. So a lot of times we see this really commonly. This is like your itchy, flaky scalp, where it's just the scalp or maybe a little bit around the nose and eyebrows and ears. This is a condition called seborrheic dermatitis. It's super common. I see it every single day. Some people think it may be on the same spectrum as psoriasis, like a more limited form. This is why I like to include it here. There's some thought too that there could just be a yeast that lives on our skin. It just lives on everyone's skin. It's not infectious. You can't rub your head on someone, they're not going to get it. But that yeast may be overgrowing a little bit. And so that's why some of the treatments we use are actually like an anti-yeast, like a ketoconazole shampoo typically works well. They can use it on their face. It's still an inflammatory condition, so topical steroids work well too. For really severe flares, you can just give them some fluconazole actually, and that works well too. But this is really common, the flaky scalp. Usually we start with ketoconazole shampoo. I like these pictures because this is what's called a petaloid seborrheic dermatitis. I see photos sometimes come through, or patients that have been referred, where it's like, oh, is this an autoimmune? Is this lupus? Like, what's going on here? But as you can see, it looks like a petal from a flower, or that's what I call it, petaloid. But this is actually just a really classic seborrheic dermatitis. It's classic petaloid seborrheic dermatitis, but it can look a little bit different. So that's why I like to highlight this, particularly in skin color. You'll see petaloid sebderm. So male pattern hair loss, or just pattern hair loss in general, I'll talk about female as well, called androgenic alopecia. This is a Norwood scale. This is what we use to rate male pattern. There's one for females. I don't use this clinically. I don't say like, oh, you're a Norwood 4 or you're a Norwood 5. This is more like a scale that they use more for like a clinical trial. It's either they have androgenic alopecia or not. Usually what I'll use is maybe photos to monitor, improvement more than just going off the scale. Family history may not play a role. Some people, it's heavily genetic. Some people, you're patient 0. Everyone else in the family's got a full head of hair, and you're just the odd one out who's losing your hair. The standard treatment is 5% minoxidil, which is Rogaine. I use the same 5% for men and women. There used to be a 2% women's strength that didn't really work at all. And so I think Rogaine finally started making a 5% women's strength because they realized the 2% doesn't really work. Finasteride, dutasteride, these are DHT blockers. DHT is a big driver, especially in male pattern hair loss. Side effects, a lot of the guys are worried about the erectile dysfunction. Depending on the study you read, it's about 1 to 4%, so it's pretty rare. I find that the men who are really concerned about getting that as a side effect are the ones that get that side effect. I don't know what that link is, but yeah, the higher the concern, the higher the stress about it, that's a bigger chance they're going to get it. It's completely anecdotal. The loss of libido, sperm count, depression has happened. Typically, though, if you stop, it's going to get better, but there's a tiny subset of men where it can be persistent. So I do counsel them about that. It's only men and women who are unable to become pregnant. I would not give this. I do not prescribe this to women who are able to become pregnant, even if they're like, I don't want children. If you're able and, sexually active, then I wouldn't prescribe it. For oral minoxidil, this is a newer one that's come out. There's a New York Times article written maybe 8 months ago about oral minoxidil, and since then it sort of blew up. It's a blood pressure medication that we're using off-label for hair loss. It's actually really low dose, can work well. I usually start them out with a quarter tablet, comes to 2.5 milligrams. So a quarter tab, if they're doing well, go up to about a half pill, so milligram and a quarter a day. Side effects. So the nice thing that a lot of men prefer this is because they don't have sexual side effects. In women, I dose it the same. I saw that question. I dose it about the same. And now when I use finasteride in women, they do need higher doses. Whereas like there's the 1 milligram for male, Propecia used to be the brand name. But for women, you really need 2.5 or 5 milligrams of finasteride. dutasteride only comes as one dose. But for oral minoxidil, I treat about the same for women. Men like it because they don't have the sexual side effects. I will say you do get increased facial hair growth and sometimes body hair growth. So I do counsel women about that as well. Headaches, dizziness are common. Very rarely you can get a pericardial effusion. So I let them know, hey, if you're getting swollen hands, swollen legs, get chest pain, stop it, let me know immediately. But this is increasing in popularity. Next slide, please. Spironolactone, this is what I use mainly for women of childbearing age who are able to become pregnant. Typically start about 100 milligrams. You can go up though. Breast tenderness, menstrual irregularities. Typically the irregularities normalize with time. If it's persistent, any hormonal birth control can normalize that. We don't really use it in men for hair loss. It can cause gynecomastia. This is what I use in women who are able to be pregnant. It's obviously not something you would use during pregnancy due to birth defects. I believe though, gender determination or sex determination is at week 6 though. So if they stop this right when they found out they became pregnant, then it would be fine. Generally, I tell them to stop about a month before they were to actively start trying to become pregnant, just to make sure. Also works great for hormonal acne. It's my go-to for adult female acne in the sort of cheeks, chin, jawline area. With all of these, I tell patients, I try to tell them give it 6 months. I think that's about what you need to see good results. You're going to have some shedding in the beginning, especially with minoxidil. That's usually the culprit. But with any hair loss medication, sometimes it gets a little worse before it gets better. I just tell them it's part of the process. It's just making way for the new hair growth. And then with all of these, you have to, with every hair loss medication, you got to keep taking it in order to keep the new growth. If you took finasteride for 10 years and then you stop it, your hair was going to revert to where it would have been had you never started. So it's not going to go back to how you were 10 years ago. It's going to go to how your hair progression would be in 10 years had you not started it. So I like to make sure they know that. So if they stop it, they're not like, my hair is so much worse after stopping finasteride. It's like, well, yeah, you're comparing it to yourself from years ago. But again, with all of these, gotta stay on them. Next slide, please. So these are both really good ones for allergic contact dermatitis. You can tell one was like probably an eye product. The other one is likely a sandal they were wearing. Probably an allergy to like a rubber accelerator. Usually with allergic contact dermatitis, it's going to be symmetrical with these. Next slide. This picture is a good board picture that you would see of like, this would be like a nickel allergy. You can see the gene button that's been rubbing up against the lower abdomen and the patient has a nickel allergy. So treatment, obviously stop whatever triggered it. Topical steroids. There's steroid sparing ointments like tacrolimus, which is what I was used for the eyelids. If it's severe, like a steroid taper. With quick note about poison ivy is the resin from poison ivy can stay on the skin for about 2 weeks. So sometimes if they have a really bad poison ivy, giving a 5-day, like the little Medrol dose pack, they may have this sort of rebound flare afterwards because that resin is still on their skin. So typically for me, when I treat poison ivy, if it's severe enough to need oral steroids, I'll give them like a 15-day course of prednisone. My usual is like a 60-40, 25 days each, usually knocks it out and works great. If it's recurrent, you can't figure out what the agent is, what's triggering it, we can do patch testing. It's either done by a dermatologist, sometimes by allergists, where we basically put these patches on their back. It's different from like the skin prick testing. This is where we put the patches on the back. They come in on Monday, we put the patches. They come on Wednesday, we take them off and do a reading. And then Friday, we do another reading. So they got to come 3 times a week. Can't shower during that week, which is kind of annoying for the patient. I try not to do too much. In North Carolina now, I was in South Carolina beforehand. In South Carolina, we definitely didn't want to patch test if we could avoid it in the summer because it was just so swampy hot. But that tells us, is it like a metal, a fragrance, something that you're coming in contact with, as opposed to an environmental allergen. Urticaria, the medical term for hives. This we do see fairly regularly. Next slide. So there's 2 main types. We call this acute and chronic. It's a completely arbitrary distinction. Chronic is just if it lasts more than 6 weeks. Acute is less than 6 weeks. And acute's usually an infection, a medication. In adults, it's usually a virus or a medication is usually what's triggering it. The kids sometimes get it, but in chronic, it's a lot harder to figure out the cause. You usually don't see kids with chronic urticaria though, but the most common demographic is sort of a middle-aged female that can have chronic urticaria. Next slide. So a couple pearls. So physical urticarias are the ones that only last a couple minutes and go away. So it's like exercise or pressure or heat, like the cholinergic urticarias. Actually, sometimes allergy is a little bit better to test for these than dermatology if you're worried it's a physical urticaria, just because they have some more standardized tests they can do. But for the most times in urticaria, like they've done studies that show you can do $1 million workup, and by and large, it's coming back negative. So the conclusion of all these studies are basically don't test for anything because it's probably going to be negative. And if you get something that's abnormal, it might not be related. And now you're chasing down this rabbit hole of something that might not be relevant. So really just a good history and physical. It's about all you need to do. I treat with Zyrtec. I like Zyrtec because the more you take, the more it works. You can take up to 40 milligrams of Zyrtec in a 24-hour period. So if someone comes in with pretty severe case of hives, I'll have them start it twice a day. If it's still flaring after a couple of days, go to 30 milligrams a day. If still going up, you go to 40, so 20 twice a day. If it makes them sleepy, you can substitute Allegra for the morning dose. I haven't found that Allegra, the more Allegra you take, I haven't found it works a whole lot better than just one Allegra, which is why I usually use Zyrtec. The studies say that prednisone is not super helpful for acute urticaria, but I have found that it does work. So I will give prednisone tapers just to sort of help make them not so miserable while the antihistamine is kind of working. So I still give prednisone. Xolair is a great medication if it's a chronic urticaria and say they've maxed out the antihistamines, they're still flaring. Xolair needs to be done by an allergist. They're typically who prescribe it. After you get the injection, you have to be monitored for anaphylaxis. So definitely want them in with an allergist for that, as they'd be like the perfect place. But Xolair is good. So if they have like a chronic urticaria, you can't get it under control, an allergist is the person to refer them to. So eczema, we talked about psoriasis before, which is on the extensor surfaces, but eczema here is more flexural. So like antecubital fossa, popliteal fossa. A lot of times we see this in the triad. We get eczema, allergies, and asthma. They go hand in hand, particularly in kids. Fortunately, though, most kids are going to outgrow this. Next slide. These are sort of things that I recommend patients who have an eczema flare or have eczema in general. So you want warm, stay away from the hot water, unscented soaps. Don't sit there too long. Pat dry instead of rub dry, because if you rub it, you're just going to irritate your skin and make it itch. And then as soon as you get out, put on the moisturizer like immediately. As opposed to psoriasis, where we don't really see infections from it. People with eczema, because that skin barrier has been compromised and allergens and bacteria can get it, we do see secondary infections for them. Things like warts. They're a wart and an eczema person. I let them know this is going to be really stubborn. This is tough to treat because that skin barrier has been compromised. Molluscum in kids with a kid with eczema is really difficult. A lot of times I'll actually tell parents, I don't know why I did it, but Cetaphil lotion seems to work the best, but put it on thick like cake frosting almost for molluscum. And you really want to heal that skin barrier, and that works really well. Cotton's best. Stay away from scratchy wool. Cool, use a humidifier. These are all things that can help. A little bit of sunshine can help, just don't get burned, obviously. I usually use the sensitive skin or mineral only. Sensitive skin and baby sunscreen are the exact same thing. They're just mineral only, so you don't have to like buy one for the kids and like buy a mineral for yourself. It's pretty much all the same. Some foods aggravate eczema. Usually you can send it to an allergist for testing. A lot of times I'll tell patients, the same thing with acne too. It's like, if you think it flares your eczema, don't eat it. With acne though, we like go back and forth like every 4 years. We'll be like, oh, milk will cause acne. And they'll be like, oh, no, it doesn't. But chocolate does. Then 4 years later, we'll be like, oh, no, it doesn't. So it's an individualized problem. So if you think it flares your acne, don't eat it. Or same thing with eczema. Again, reason 835 to not smoke, it'll make your eczema worse. As far as treatment, it's usually topical steroids. Again, triamcinolone is good for the body. Triamcinolone is the only one that comes in a really big tub too. You can get it in a 1-pound jar for people who are just covered head to toe. Destinide is a good one for the face. in general, an ointment is better than a cream because it's just the medication and like Vaseline. So very few other potential allergens as opposed to creams. But some people just don't like the greasy feeling. So compliance is sometimes an issue. Antihistamines, they can help with the itching. They may dry them out. So just make sure they moisturize a lot. Phototherapy, similar to psoriasis. We talked about some bathing moisturizers. Keeping the nails short, especially in kids. There are systemic medications now like Dupixent. There's some other coming. Dupixent is an injection. There's a pill now. Pill actually has way more side effects than the injection. So I usually try to talk them into the injection for eczema. Next slide. So this is something that can help in a pinch if you have someone come in and it's either eczema or psoriasis or just a terrible dermatitis that's all over the place. You do this thing called wet wraps. This is a huge hassle, but it works really well. Whenever I've made patients do this, they always come in and like, that was horrible. I never want to do that again. But I was like, but did it work? And they're like, it worked amazing, but I don't want to do it. But if it's bad enough, they'll do it. So basically what you do is you bathe and pat dry. And when you're still a little wet, you're going to put Vaseline or the steroid with Vaseline on top or Aquaphor. And then you take some cotton pajamas or a shirt or something, and you're going to get it wet in lukewarm water, wring it out. You can use a sauna suit instead, and then put that on. And what that's going to do, it's like if you ever jumped in a pool with a shirt on, it's going to cling to you. And it's going to force, it's like occlusive. It's going to force that steroid and force that moisturizer in. And on top of that, put on a bathrobe or something dry, you know. And if you can leave it on overnight, great. If you can just leave it on until it's dry, that's awesome too. I usually tell them to just watch a movie. Or if it's a kid, put them in front, you know, this is iPad time or whatever, let them watch a show. And then you just keep on till it's dry. And this done for like a couple days works amazing. I mean, I've taken babies that have like horrendous eczema and doing almost nothing but wet wraps. See them back a week later, it's a brand new kid. It works really well. Quick thing I want to talk about moisturizers. They come as lotions, creams, ointments. Lotion, that's usually your pump bottle. It's not greasy, but not a great moisturizer. Whereas like ointments are your other end of the spectrum. It's like your Aquaphor, your Vaseline, a little greasier, but a great moisturizer. Creams try to be that Goldilocks in the middle. It's usually going to come in the tub again, but it's not too greasy, but moisturizes a lot better. That's where most people, I recommend looking for a cream. There are very few like creams that come in a pump bottle though, so it exists. And Aquaphor comes in a spray can. I don't understand what sort of sorcery Eucerin did to get Aquaphor in a spray, but it does come as a spray for people who don't want to like apply it with their hands. So just in summary, like a lot of conditions we can evaluate virtually with really high quality photos and a good history. Like we can do a lot of virtual dermatology and we can get you an answer of, hey, this is where we go from here. Is there going to be a time where we may say, yeah, if this isn't helping, probably needs to be seen in person for, you know, a medication that needs, that needs like a systemic medication, because some of the systemics require prior, like you would be perfectly capable of prescribing if you want to, but some insurances are like, it's only a dermatologist or an allergist can prescribe it annoyingly. So that's why sometimes we'll be like, send it to them for a biologic if this isn't helping. But the more we get, the more we can help. But again, we can do a lot with good quality photos and a history. Any
Dr.
questions?
Beasley, thank you. I'll also chime in. Thanks for, I think we got through the questions in the chat. And you saw the minoxidil finasteride question prescribed in combination?
Oh, sorry, I missed that. Yeah, you can do finasteride and minoxidil as well. Usually I'll do like a milligram of finasteride for a male, milligram finasteride and like and up to like 1.25 1.25 milligrams of minoxidil. And that works great. Yeah, it's a great combo.
Alrighty. Feel free to throw questions. We do have some questions that we've pre-populated that we've also received in advance. So we'll go through a couple of those since we have time. But feel free, everyone's live here today. So if there's questions specifically on the content, if it's not about the content, of course, we'll try to answer, or things that you're seeing or wanted to know or just curious about. I'll also just highlight for a second, because I know I just really did dive in. At Modern Ritual, we do have a rapid virtual dermatology service. So we have a network of board-certified dermatologists licensed across the US who partner and provide consults to non-dermatologists and to patients directly. So again, This is kind of what we do all day in, day out. I see another question. For finasteride in women, you mentioned women who can't get pregnant. Do you generally recommend two contraceptives like Accutane?
I actually don't. If you're able to be pregnant, you're not a candidate for me. Reason is, so Accutane's out of your system in about a month. You're gonna have to take pregnancy tests every month. So like you're coming in a lot to have that. Whereas, I mean, you could do pregnancy tests every month, but the problem is finasteride is gonna stay in your system for like dutasteride may stay in even 6 months. So if they were to get pregnant on the medication, there's no way to prevent fetal exposure. Even if you stopped it immediately, that it's getting exposed. So is it a never? It's not a never. I'm sure if someone catches me on the right day and tells me the right story, the right combination of story, maybe. But in general, I mean, if it was like I've had a tubal and my husband's had a vasectomy, then it's probably all right. It's probably not happening. So I guess never say never, but in general, I don't.
We have another one about, oh, sorry, Dr. Beasley.
Oh, sorry. Yeah, I saw the chat. Advice as far as sun protection. So for me, I'm a big fan of mineral sunscreens. Sometimes these can be sort of pasty white. But if you ever see my kids show up to the pool in the summer, they're dermatologist kids because they are pasty white. They're in their sweet sun shirts. But we've come a long way, and there are more elegant mineral sunscreens that are out there that do go on clear. Usually the ones that go clear have a little bit of a chemical component as well, which is fine. There are some that have tints to them that are mineral, and there is fortunately, we're actually seeing more mineral options coming in for skin of color, which is really nice because before it was really limited. Whereas now you're having some, like I think Supergoop makes one that's a mineral only, and you can match I mean, they don't have every tint, but we're getting better. But you can sort of match a tint closer to your skin tone, which is really nice.
And I'll also highlight, just because I saw this weekend, we actually at one point developed a sunscreen and went through and saw some of the worst to the greatest, and I was the kid who was slathered from head to toe, and all the scar and the trauma. The one thing that we talked a lot about this weekend around, I had a friend who said, I applied sunscreen so well, you'd be so proud. I said, well, why are you so burnt? And like, well, I didn't reapply and I was wearing sunscreen. And so I think the biggest lesson that we've seen is sunscreen is amazing, but the hat, shirt, cool shirts with coolie bar. We actually have a blog post on some really great options for sun protective clothing as well. And so just thinking holistically, full lifestyle. I'm not the dermatologist again, but I think that I'm the one who people, still come to somehow on the side. And so I say, find a great sunscreen daily, but don't make that your everything.
Yeah,
I know we have some other
totally
questions in
agree.
the chat, so I was going to prioritize those, if that's okay with you, Dr. B.
Yeah, that sounds great to me. So it looks like there's a question about collaboration. I mean, everyone, it's up to you, whatever, you feel comfortable doing. I don't do a ton of cosmetics personally, so this is sort of outside my scope. I mean, I've worked with NPs and PAs who are fantastic, and it's all what you're comfortable with, and what they're comfortable doing.
And then I'm happy there one on tinea corpus. If large spread tinea corpus or capitis is suspected, should we start griseofulvin or, hopefully no one's judging, or out plus KOH out of clinic?
Oh yeah, so do you have to get a KOH if you think it's tinea corporis? I don't always, if it's pretty classic, then I don't always go and get a KOH. If I'm a little unsure, I'll go and do a scraping myself. If it's the one where you're like taking it and sending it out and it takes like 6 weeks to come back, then I would probably just go ahead and treat. I usually use terbinafine more often in adults. Griseofulvin's more for kids for me, for tinea corporis. One quick note about that is like every dermatologist like least favorite topical in the entire world is like the combo steroid antifungal creams. Like we can't stand them. There's like only one condition I'll ever use, like maybe two conditions I'll ever use them on, but just pick one. Like use the steroid or use the antifungal. Like if you put a steroid on a fungus, it'll get worse. And when you see them in follow-up, you're like, oh, well, let's actually switch. Or if you put an antifungal on eczema, like it's going to moisturize a little bit, but like just pick one. Because when it doesn't work and they come to us, that's usually like we're sort of stuck now. And we're like, well, I guess like we need a biopsy. Whereas starting one, it's a point of contention in the dermatology world. Stay away from the combo creams. I use them sometimes for intertrigo, very rarely, and like an angular cheilitis in the corners of the mouth. That's about the only time I use it.
Dr. Beasley, we have one that says, what are the best practices for performing a basic skin examination in a non-dermatology setting?
It looks like there's one above about benzene and sunscreens too.
Oh, yes. I was actually going to link. We do have an article we wrote that Dr. Goldstein, our co-founder, wrote on benzene and sunscreen, but I'm curious to hear if you have any thoughts on it.
Yeah, that's why I always recommend mineral only. That's what I use, mineral only sunscreens anytime I can. I just stay away from the chemicals. There hasn't been linked. Like there was, we've had studies where it says, oh, well, there's like the chemical gets absorbed, we found in the bloodstream, but we haven't found anything that's harmful from it. But in general, I default to a mineral sunscreen because it's going to sit on top, and zinc, titanium, and iron are your friends.
Yeah.
As far as best practices for performing a skin exam, what you are looking at, you have the A, B, C, D, E's, right? Asymmetrical, the borders, colors, diameter. The diameter ones, personally, like I've seen plenty of bowls that are bigger than a pencil eraser. It's the E is the most important one, evolving. Is it changing? Slow change over the years, not quite so concerning, but like rapid change would be more concerning. We actually get a lot of mole questions at Modern Ritual. We plug you in, we get you this thing called a dermatoscope, which gives me this like magnified, polarized view of it where I can see the pigment network. And it really lets us, a lot of times it's like I'm there being able to examine see the patient, see what you're seeing with that. And it's really helpful. And it's probably one of the few, probably the only service that will actually do with the dermatoscope, which is you really need, the dermatoscope's really important when you're looking at a mole. I would be so lost without mine in clinic. Looks like there's a question about emerging trends in dermatology.
We'd like to thank us. If you want to,
yeah, right.
Other webinars that we host on a monthly basis on new and emerging trends, which we'll send a link out to some of those. But Dr. Beasley, if there's other resources that
there's a lot of virtual care is big in dermatology, like Modern Ritual, which is really helpful. Their oral minoxidil was a big one as of 8 months ago, like if that would fit the term of emerging in the last year, just with the New York Times article. It was like overnight, it suddenly became crazy popular to the point where pharmacies were totally out of it. So that's probably, there's a lot more treatments coming out now for eczema, like systemic treatments, which is nice. Again, now some are pills, used to only have an injection version. The pills do have more side effects, but they're there for people who just absolutely will take the side effects over a shot. So there's a few things coming out. How can the non-dermatologist, there's another question about the non-dermatologist stay up to date. I'm like constantly reading to stay up to date myself. So like this is a total struggle for everyone to like stay up to date in CMEs. There are the journal articles, the derm journal articles are probably a bit in the weeds because they're talking about inpatient medicine. There are I use a lot of up to date. I think up to date is great. If you have that, that's a great way because they're updating it pretty regularly. So up to date's a great way to like learn of, hey, this is what, if it says this is what our treatment algorithm is for tinea corporis, it's probably going to be really good.
you might even see Dr. Goldstein's meeting plural for Bether, my father, because they did, I think, a lot of the OG up to date in dermatology for primary care outside of it.
Oh, that's awesome.
We only have a couple of minutes left, and I see some really other great questions coming through. I'll also highlight, again, we do these monthly. We're so lucky to be with Zivian again here for this one. And then we also with Modern Ritual do ongoing education as a part of just working and getting to collaborate. Maybe Dr. Beasley, we can do one more question.
Yeah, I will say too, like as far as like continuing dermatology education, like the nice thing about Modern Ritual is like we're giving you a feedback as opposed to like when you get the referral, like, I mean, I'm sure you're going over their notes and everything, but this is like a direct feedback of a patient you just saw or just, just started the consult with. So it was like, it's still fresh in your mind when you're getting that feedback of, hey, this is what I think it is. This is my algorithm. This is what I would do. So I think that really helps reinforce things as well. This question about La Roche will say, La Roche is like I love La Roche. I think it's great, super high quality. That's what we use a lot in my house is either that. Elta MD is also a really nice product. But we use a lot of La Roche.
Retweet on the Elta and La Roche.
Yeah, I like Elta. Elta MD is really nice too. The Woods lamp, I mainly use a Woods lamp for like vitiligo, where I'm trying to decide, is this like completely depigmented or is it just a little hypopigmented? That's where I use it for. But Woods lamp for me, some derms probably use it more than others. I don't use a wood lamp a ton. And then last question is hair growth treatment vary. There are different types, like for like male pattern or female pattern hair loss, not really. It's pretty much the same because it's driven by this similar process. But there are certainly causes of other types of alopecia, which is a term for hair loss. There are types of alopecia that affect sort of like different skin types for sure. And so I did a lot of training in my residency in hair loss. From my mentor was. Her mentor was the guy who literally wrote the book on hair loss. So when I was going through my training, she's like, you will learn hair loss. If it's the only thing you get out of this resident, like you're learning hair loss. So I'm very comfortable with it. And so it is, there's different types of hair loss that you will see, but for androgenic alopecia, it's pretty similar treatment.
All righty.
Cool.
Dr. Beasley, thank you so much. Really, really appreciate it. And Jaden also as well, and the Zivian team. Again, our email here just to get in touch. Also, if you just want to chat or have follow-up questions or connect with Dr. Beasley, who's also a wonderful just colleague, and we love to make these connections. Jaden, anything else from your side before we wrap up?
No, this was amazing. Thank you so much. Yeah, this is great. I learned so much already.
And exactly on the dot, like we say, 40 at the 45. So that's always our goal. Everyone, just enough for a lunch hour.
Exactly.
I'll go ahead and I'll stop sharing here. But this was recorded. So if you didn't get a chance to hear the beginning, I think we'll coordinate on getting this information sent out. And if there's anything else that you want to see in future sessions, do reach out. But we'll send out information on how you can continue to connect. Thank you all so much.
Thank you, Dr.
Thank you, everyone.
Thank you, Eliana.